Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call. Questions can be submitted at any time during the presentation using the Q&A feature located on your control panel. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Stillman Bridges and Ernest Williams. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the View feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda topics include introductions in MH, SU, IDD, TBI system announcements, and updates. Our focus today is the collaborative care model, enhancing behavioral health, integration, and primary care. At this time, I would like to turn over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Hello, everyone. It is great to be here. Welcome to today's webinar. So today you are actually going to have a lot of guest speakers, which I'm really excited about. And I'm excited about the topic. More on that in a second. So I am Kelly Crosby. I'm the Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. I've been in this field for a very long time. I just celebrated my 3rd year anniversary here as the Division Director. I've been almost 15 years now in the department. I am a licensed clinical social worker, and I am a proud person with lived experience. Next slide, please. So we have very simple updates today because we're going to spend the bulk of the time talking about collaborative care. So next slide, please. So obviously, we want to talk about honoring Black History Month, which is February. So I'm very honored to celebrate the contributions of Black Americans here, and also their incredible contributions to the field of mental health, substance use, and IDD. One of the things that we're always thinking about, and we should certainly continue to think about this month, is we need to make sure that services are available and accessible for all. We know that services are not always available to individuals in the Black and African American communities here in North Carolina. We need to make sure that services are culturally humble and appropriate, and we're doing everything we can to make sure that people are able to seek care without stigma, and seek care in the ways that make the best sense to them, feel the most comfortable for them, and are the most effective from them. So that is part of our mission here at North Carolina, and we will continue that mission. I don't have a slide on this, and I'm sorry about that, but I do want to say Happy New Year to our Chinese American colleagues. So it is the year of the horse. We celebrated Lunar New Year over this weekend. And I want to remind folks about our wonderful Turong program, which is aimed at, again, providing accessible care, more training and awareness to members of our AAPI community. That's led by Pooja Mehta here at our division. Want to shout out and appreciate our partnership with UCA Waves, which is trying to increase services and supports and training to the Chinese American community here in North Carolina. So again, want to lift up another community where we are proud and pleased of the contributions of Chinese Americans here in North Carolina, but also want to recognize, again, an underserved group where there's a lot of stigma around asking for help, seeking care, and we need to make sure that we have culturally humble and appropriate services. Next slide, please. So today we have 3 esteemed panelists that I am delighted to say that I've worked with for many years, and I'm very glad that they're here. Before I turn things over to Dr. Keith McCoy, who's going to MC and navigate all of this for us, I want to remind folks why we're talking about collaborative care today. So I think it came out, I think the announcement came out, but our annual report should have been posted today. And our #1 priority is actually increasing access to care. And one of the ways that we are focused on increasing access to care is making sure care is available in many places and spaces. Collaborative care is one of those models of care. It's an evidence-based model of care. And the panelists today are actually going to talk about some of the data that we're seeing in North Carolina. So why is collaborative care important? It's evidence-based. It helps people get care. This is really critical. It helps people get care in primary care. So we all know, again, even in 2025, there's a lot of stigma about searching for mental health, substance use support, lots of stigma. People don't often know where to go. People often have a relationship and feel more comfortable talking to their primary care doctor about how they're doing and feeling. There's been extraordinary effort here in North Carolina to help primary care physicians screen for things like depression and anxiety. And think about kids. Most people go to their pediatrician to talk about ADHD or anxiety in their child, school anxiety and issues. So that really is a trusted place where a lot of people go for mental health and in some cases, substance use care. So we want to make sure that we have primary care docs who are equipped to help that person manage their depression, their anxiety, their child's ADHD, whatever it is that is happening there. Because if people can get help in primary care and it's effective help, then we know that they're much less likely for their issues to get worse, more challenging, and then need more complex types of help. So this is a really exciting model. You're going to hear from the team leading the way. And I just want to say thank you to them. Thank you to Dr. McCoy. Thank you, Eric. Thank you, Chris. Thank you to your teams for all the extraordinary work that you're doing, because so many people are getting the care that they need, and it's being effective. And that's really exciting. So want to appreciate your teams and you guys for all the work that you've been doing across North Carolina for the last few years. So Dr. McCoy, I'm going to turn it over to you.
Great. Thank you so much, Kelly. And I really appreciate that intro that sets us up to be able to celebrate a lot of the investments that we've been able to make in collaboration across the department with our legislature and with our community partners to invest in evidence-based treatments in primary care settings through the collaborative care model. So with me today is Chris Wethington, who comes to us through NCAHEC. He's the Director of Practice Support there, and he'll be talking with us a little bit after Eric Christian, who's joining us today, who's the Director of Behavioral Health Integration with Community Care of North Carolina. So these NCAHEC and CCNC have been critical resources for us to be able to effectively promote and expand this model within the state of North Carolina. We can go on to the next slide. So the collaborative care model is a model. I'll go through in just a second what the structure is so you have some more context for it. But just so you know, it's a highly evidence-based model for integrated care into the primary care setting. There have been over 90 randomized control trials. It was developed at the University of Washington out in Seattle. I think initially it was primarily focused on depression in older age, and it's designed to help integrate mental health services into those primary care settings, where, as Kelly outlined, this is the place that a lot of people feel most comfortable. It's a place that has resources to be able to address especially mild to moderate mental health and substance use conditions. And it's a way to allow people to get care as close to their normal way of receiving care as they're used to. Again, it's designed for assessing, so screening for, assessing, treating mild to moderate mental health conditions. A lot of the research is focused on depression, anxiety, post-traumatic stress disorder, but also to an increasing degree, some substance use disorders. It produces superior outcomes, particularly around symptom reduction, but also with satisfaction for clients and clinicians compared to treatment as usual, which often is either the primary care physician treating on her own or just referring to outside services and hoping that there's a connection made between the person receiving care and the treatment system that they are being referred to. It also tends to work well for individuals who do have some significant physical health comorbidities. It's been studied in individuals who have cancer, who have diabetes, who have HIV. So it's a really robustly studied and implemented model. There's significant return on investment as well for payers and states who are interested in trying to maximize the resources we have and improve outcomes, including reducing emergency room visits, reducing inpatient hospitalizations, those sorts of areas where we don't want to see unnecessary utilization. Next slide. So obviously there's a lot of need. We've been talking about this, I think, increasingly for the past number of years, that 1 in 5 adults live with some sort of mental health condition. Over 1 in 5 youth, particularly adolescents, have a serious mental health condition. And then 11.4% of the need is met by the current number of available psychiatrists in North Carolina. So I do want to highlight that collaborative care is not just a means for more efficient prescribing. It also comes with interventions that are psychosocial, psychotherapeutic in nature, and oftentimes individuals with mental health conditions can be treated successfully without the need for medications. But it does allow for, as we'll cover in the next slide, which we can go ahead and go to, psychiatrist oversight to ensure that those individuals that are being screened, that are being assessed, that are being treated, are responding appropriately to care, that they're making progress, and that if they need additional assessment and referral to more intensive community resources, that's happening. So this is what the collaborative care model looks like. It's a team-based approach, again, based in the primary care setting. The primary care provider is who bills for this. So even if the primary care provider is not directly providing the services, it's under that individual's licensure and NPI number that we use, where all the other activities that happen get billed through various CPT codes. And CPT codes are codes that are nationalized for medical billing. Really, the primary position that makes this model work, though, is not the primary care provider. It's the behavioral health care manager. And the behavioral health care manager can be a licensed clinician, but can also be another staff member in the primary care setting who's received specialized training to be able to provide the interventions that are part of the collaborative care model. And then there is a psychiatric consultant that predominantly works with that behavioral health care manager. Together, they build a registry of individuals who have been screened for a given condition. So a primary care practice may choose to screen for depression. It may choose to screen for anxiety, may choose to screen for alcohol use disorder. They can pick multiple different conditions to screen for. And then they will also pick a target population. So they may pick older adults, as the model was originally designed for. They may be picking to focus on adolescents. And once they do that, everybody who meets those criteria will get screened. Those who screen positive will get a more in-depth assessment and diagnosis. Often that diagnosis is going to be by the primary care provider. Individuals will get put into a registry, and then they're monitored with evidence-based monitoring tools to measure symptom severity. And so they'll get reassessed intermittently for how they are responding to treatment. That could be, again, psychosocial, psychotherapeutic, could be medications, could be lifestyle interventions, any number of things. And those who are getting better, you'll see their scores correspond to getting better. Some will plateau, some might get worse. And it's that psychiatric consultant that works with the behavioral health care manager to decide who needs to be referred for more intensive treatment, how do we need to adjust the treatment, how does that psychiatrist help the primary care provider adjust medication prescribing if that's what's being done. But it really does systematize a process for screening, assessment, and treatment for a certain condition in a certain population in the primary care environment. And that primary care practice can select where are our greatest needs. What is it that we're seeing go untreated? Where are we having trouble referring people in the community, so that then we can do a better job in the primary care office of addressing these conditions and making sure that mental health and substance use conditions are getting the same level of evidence-based attention as physical health conditions like diabetes and high cholesterol. Next slide, please. So in North Carolina, after COVID, there was a pretty strong realization at the state level that our primary care offices were doing a tremendous amount of mental health and substance use work, and they needed support to do that. We in North Carolina Medicaid had covered the codes that are reimbursable for collaborative care since 2018, but we had not seen very much utilization. And so we decided to form a consortium of internal folks within the department and also external stakeholders, including CCNC, including AHEC, but some of our health plans, some of our professional associations representing family practice, representing pediatrics, representing psychiatry, and decided to put all our heads together, figure out what are all the barriers that are preventing this highly evidence-based model from being implemented, and then let's start to tick away at those. What can we do to try to address those? So we found that payers across North Carolina, so Medicaid, our commercial insurance plans, were not all paying for collaborative care. And when they did, they weren't all paying for it in the same way and didn't necessarily have the same requirements for it. So we did a process of alignment that would allow us to align with Medicare, which really got this started within the public sector, and we needed to align with Medicare. So we did that. We promoted coverage across North Carolina payers, and we have strong coverage across North Carolina now. Within Medicaid in 2023, we increased reimbursement to 120% of Medicare and have maintained that based on 2023 Medicare reimbursement rates. We removed copays for beneficiaries. So sometimes in Medicaid, you've got to pay a $4 copay. We removed that as part of this because a lot of the work that goes on in the collaborative care model, it's not always directly with the individual receiving care. There's that work that care manager and psychiatrist do behind the scenes. There's the work that the psychiatrist and the primary care physician do behind the scenes. And so we wanted to make sure that people weren't getting charged $4 copays and they're like, hey, nothing really happened here that I understand. We created and implemented a technical assistance program with NCAHEC, which you'll hear about shortly. We worked with the North Carolina Psychiatric Association to identify trained psychiatrists that could be matched with primary care practices, developed even a model contract to be used between those practices and psychiatrists so that those psychiatrists could be the consultant for those practices. We have purchased for, I think, 3 years for interested practices, a registry that can be used because that collaborative care model requires this registry be built that tracks everyone you've screened, how they score for that screening, and what their progress is with treatment. And then we also realized that a lot of capacity building is needed. Primary care providers operate often on a shoestring budget. There's not a lot of profit margin there. And this model requires some upfront costs, particularly hiring that behavioral health care manager to be able to build a caseload. And that can take 6 months, sometimes even up to a year. We've gotten a lot of attention for what we've done. And you're going to hear a lot more about the capacity building funding from CCNC, from Eric here in a minute. But we've also published what we've done. I put the link in here. These slides will be available to everyone. I know they've been put in the chat if you want to read our white paper about what we've done. And we've gotten a lot of attention from other states asking us, what did you do and how can we do it? We'll show you a little bit of the results of what we're seeing as far as billing if we go to the next slide. So you can see we've really seen a strong uptick in the number of providers, primary care providers who are billing for this. So this data goes all the way back to January of 2019. You'll see that on the far left. These are months throughout the year that each bar represents. And then on the right, you'll see the number of billing providers. So we've gone from, for a long time, having maybe 20 to 40 providers bill this within the Medicaid system to over 180 as of the end of 2025. So this is very exciting for us. Again, this has a strong return on investment for us. So we see usually Medicaid savings when we see more collaborative care. So this is one of those places where we're not terribly alarmed at a substantial increase in utilization because we know it means that the system's doing what it's supposed to. Next slide. And this is the number of members receiving collaborative care by month. So you'll see we were ticking around 200 to 400 until we really started to see some of our efforts be implemented in 2023. And then you'll see we've had a significant uptick upwards of around 1,600 members per month getting this. And this is not a service that someone's going to get forever. This is quite time limited. You expect folks to either improve, or if they don't improve or plateau or get worse, then they get referred to other services. So it's not that we're seeing the same 1,400, 1,600 every month. It's going to be new people coming in and folks that are getting better, getting referred out, dropping off from this specific evidence-based intervention. Next slide. All right, with that, I'm going to hand it off to Eric.
Thanks so much, Dr. McCoy, and thanks for the overview. We're going to talk a little bit about the funding and capacity building funds that Dr. McCoy mentioned that have been provided by the state. CCNC, Community Care of North Carolina, the company I work for, we're facilitating the funds on behalf of the state. Next slide, please. This is just a picture of our splash page and our webpage, and the link to that is in the chat. Thank you, Brianna, for posting that. Next slide, please. And on the website, you can find out all the details I'm about to present, including the way in which the awards are laid out. There are $50,000 awards for practices who are new to collaborative care, meaning that they've not billed for it in the last 6 months. And we call those phase 1 practices. And this $50,000 award is distributed in three increments. And these increments are really laid out, which I think is really wise, and the planning committee helped to establish this to get practices to really launch that service and start seeing patients. Because it is incentive-based as they move along longitudinally to set up services, they get more payment as they go. So the first is that they'll receive after a successful application that's been reviewed and validated based on the requirements, and we have practices then signing a participation agreement, is that they'll receive their $25,000, their 25% or $12,500 worth of planning funds. And practices should be thinking that they're going to be implementing within 6 months when they're seeking these funds. And many have implemented quite a bit before then, after receiving their funds. Then they're looking at their implementation funds, which is half of their funding at $25,000. That's when they've hired or contracted a psychiatric consultant. Usually it's about 2 hours or less of time per week per caseload that they're engaging that consultant. Their behavioral health care manager, which could be part-time or full-time, that may be a contracted employee or maybe somebody on staff. And then their funds will be distributed within 30 days of letting us know that they've secured these staff and they're about to begin their service. Their operational funds will come last with the remaining $12,500 when they've established a panel of patients with a minimum caseload of 20, again, helping to move towards ramping up that services and getting it towards sustainability. Their services must still be in process. They're beginning to file claims in order to meet these criteria. And then they're submitting monthly documented caseload numbers reported through an electronic jot form to CCNC every other month, although we are collecting monthly data. So every other month they submit 2 discrete months of data. And we're going to take a little bit of a look at that in a moment. Next slide, please. So there are two other kinds of funding for practices in different phases here. These are practices that either phase 2A, those are practices who've already adopted COCM, collaborative care, but could use some funding to make their model better. So perhaps they want to hire a whole person for the caseload, maybe that the original care manager was sharing their duties with other functions within the practice, or perhaps they never began billing, or they had trouble with billing, or they're something else that would improve their program. And of course, that would be part of their application. Practices in this phase 2A are eligible for $30,000, and it's distributed in 2 payments. Excuse me. And then there are practices in phase 2B, and those are practices that would like to use a third-party turnkey vendor. That vendor would supply them with the registry, and we'll get into some detail about what that looks like. They would provide the behavioral health care manager and the psychiatric consultant. So basically the package that the practice would need to implement, and they would run that service for the practice, and billing would still be done through the medical practice because it's all done incident to underneath the primary care provider. But the criteria are similar, although there are 2 payments here. Upon receipt of an eligible application that's been awarded, they'll sign a participation agreement, and they will get their planning funds, whether they be turnkey, phase 2B, or a practice that's already up and running, like a phase 2A, but needs some help to bring their program to where they'd like it to be. And then the second payment would be the implementation funds, the second 50%. And that's when they are either, they've got their staff in place, either hired or newly hired, or their third-party staff in place from the turnkey. And if they're a phase 2A, those have already adopted, they've increased their caseload by 20 patients. So now they're able to expand, they've moved their caseload up, and they're meeting criteria. Or if they are a turnkey type of application, a phase 2B, they've got 20 patients on the caseload, showing that they're moving in the right direction, they've begun billing or they've continued billing, and they're submitting their caseload reports. Next slide, please. So to talk a little bit about registries, and I know Dr. McCoy covered it as an essential portion of the service. It is a mandated component of collaborative care. Some medical records do have registries within them, but often they're missing some components where they may not track the population at large, the caseload itself. They may track it at the patient level, but here this registry will track patients at both the population level, the caseload level, and at the individual level. As I mentioned, it's population-based. You can separate groups of patients into different categories, those that are improving, or those that are not improving and need further attention, those that are brand new and should be reviewed. And so it allows the consulting psychiatrist and the behavioral health care manager to really look at that population, see who needs their attention each week that they meet. You track your patient's treatment to target, meaning that it's a longitudinal reassessment. So the patient has an initial score, there's scores in the middle, and then scores that would then tell you that they've improved or even gotten to remission and should then be moving off the caseload within 90 days. It provides a summary of the caseload, also will help you to track time spent, which is how billing is done. By the minute, each patient's insurance will be billed 1 time per month for the cumulative minutes spent. So 5 minutes here and 20 there would be tracked on the registry and allow you to more easily summarize your time at the end of the month and submit an invoice. And it condenses and calculates all the data points that are part of collaborative care, some of which we'll see here in a moment in some of our caseload data. Next slide, please. So the state has put aside a separate pot of funds for registries, for practices, for primary care practices who are interested in accessing the North Carolina version of the AIMS caseload tracker. With our committee, our clinical committee, we did design a version for North Carolina. Practices have access to this version of the registry with this funding, but even after the funding is gone, you can still access the North Carolina version of the registry, which has screeners in there that are tracked longitudinally for depression, anxiety, PTSD, and ADHD. for adults. Actually, for children, the PTSD is for adults. Those are the only two age groups that go one way or the other. But it's quite a bit of savings, $4,600 per year. So you pay for it once a year, all at once. And then $2,600 for safety nets like FQHCs, local health departments, and rural health centers. They get a discount. And if you're interested in this, you'll be contacting your AHEC coach, and Chris will be talking about that in a few moments. And they would make the referral saying, yes, this practice looks like they meet criteria for use of this, and should then be able to have their invoice paid by Community Care North Carolina on behalf of the state of North Carolina. Next slide, please. So this is a snapshot of our dashboard. So when practices send in their electronic jot forms every other month, we collect the data, and that is used by the committee to make decisions. And it's exciting that we're able to kind of see what's happening at the practice level. So here on the top left, you can see that there are 71 practices who have been recipients of this award to date. 60 of those are phase ones, meaning they're new to collaborative care with the $50,000 award. Phase 2A, those are practices that were already doing it but could use a boost and receive the $30,000 award. There are 7 of those. And then phase 2Bs, those are the ones using the turnkey vendor who provides everything that you need. There are 4 of those. The second number there in the light blue, the 22, next to the phase 160, for example, those are additional sites. So a site may have been awarded and they're sharing it with their sister location across town, sharing that caseload, sharing the care manager. And we're able to kind of just keep track of that as well, which is great, knowing that that care manager might be splitting his or her time. And so altogether, there are 98 locations that are impacted by this funding. When we look to the next square to the right, registered by ownership, we can see how it plays out across the different types of primary care locations. Family medicine being in the lead with 28 awards to additional locations that 2 of them have spread their awards to. Pediatrics at 17, internal medicine at 10, FQHCs at 7 awards, health departments and rural health centers each with 1. And OBGYN practices that have a medical home population are also eligible to apply. We just have not heard from any as of yet. And then down below that on the right, you'll see the practice type then aligned with the ownership. If practices are independent, those who are independently owned make up the majority of the awards compared to those that are hospital owned. So we're glad to see that for a number of reasons, in that the goal of this funding is to also support practices that are in the lowest socioeconomic areas. And your next slide here will show you how that has played out thus far. Next slide, please. So this map here shows the different counties in North Carolina. The tier 1, 2, and 3 are by socioeconomic level of need. Tier 1 being the most need. Those counties have fewer resources, and people travel further for care and have more difficulty finding care. And you can see here in the tier 1 counties, where the first number in a county is the site awarded, the number of sites awarded. The second one is if they have a sister site that they're sharing their funds with. And so we can see here, if you look up, probably notice where your counties are, because that's where my eye goes to, where I live in Buncombe. All the way to the left there, we are now at tier 2. We had moved from a tier 3, which is the sort of the least distressed, to a tier 2 that may have been due to Helene. But we have 4 awarded sites, and one of those sites is sharing with a sister location. Next slide, please. And here we're looking at the practice caseload dashboard. So we get details on at the caseload level. And here you can see how things have continued to climb each month, which also was reflected in Dr. McCoy's slides for PCPs, billing, and patients receiving services. And the last complete set of data is for November. So you can just focus your eye there, where we have 1,600 total active cases, 1,633, and 256 new cases. So that's in addition to the 1,633. that are coming in. So we continue to see this decline each month as more practices are getting that last payment because they finally hit 20 patients and are billing and doing those things. So it really should start to ramp even more soon, because we've got a number of practices that have been awarded in the last couple of months, and they'll soon be starting to see patients. And then cases for improvement, the box to your right, this is the most exciting part of it, because these are the clinical outcomes. If we look at November 2025 being the last complete month of data, we have 508 cases with improvement, meaning that their depression score, for example, has gone down by 50%. And then 350 cases in remission, meaning that their depression score is below 5, therefore not trackable. They would not have been seen as having depression. There never would have been a referral if those 350 people were screened today. So they are in remission for depression. And that's not a score that everyone can get down to, but we're really excited to see that number, and of course to see these numbers grow. Next slide, please. So the way in which you get rolling with all of this is to contact AHEC for practice support. So I'm pleased to have Chris Weatherton follow me right now and talk more about North Carolina AHEC's practice support. Thank you.
Thank you, Eric. Good afternoon. On behalf of NC AHEC Practice Support, it's a privilege to actually be able to work in this space with everyone who are truly committed to helping these patients with these behavioral health needs. What you see here is a photograph of Novant Health Twin City Pediatrics in Winston-Salem. Dr. Gretchen Hoyle's office, our practice support coach with the white shirt. She's right next to Dr. Hoyle, and it helped her implement collaborative care. And we're going to talk a little bit more about that as one of our success stories. Next slide. So we have 23 practice support coaches located across the state of North Carolina that are available to primary care practices that are interested in either implementing or sustaining the collaborative care model in their practice. And all of this help is at no charge due to generous funding from North Carolina, DMH and DHHS. The practice support, what we do is we provide expertise in the collaborative care model implementation. We can help you with pro forma development to see if this is a good fit for you financially and if this is a sustainable model. It is a sustainable model if the billing and coding and the patient panel is properly optimized, but we've been able to show some examples of that, and I've got a success story to share with you in a moment. We help you with an implementation checklist with you and your staff, with workflows to make sure that you're doing this in a standardized way and as efficiently and effectively as possible. We help you with the billing and coding, and Eric mentioned earlier that these are time-based codes that are billed once a month, but we can help you should you experience any claims denials or issues with your EHR billing. We help you optimize your EHR. For example, we can help you identify the appropriate patients out of your EHR that would be an appropriate fit for this model, and then also look across other physical health or chronic disease diagnoses where maybe perhaps patients have been constantly readmitted to the emergency room or the hospital, or have diabetes or hypertension or some other chronic disease, and making sure that we're actually moving the needle on closing care gaps with the physical health population as well. We can help you with the registry implementation and the continuing education programs, and a coordination of the referral to CCNC. So all of this good information that has been provided this afternoon, you do not need to feel that you need to remember all of this. We can have a practice support coach to help you walk through every step of this journey. And you can reach out to us at practicesupport@ncahec.net. I mentioned educational courses. These are provided with educational credits, all virtual, where you can take up to 33 courses. You do not have to take all 33 courses, but you can take a subset of those to meet your needs. But you definitely need to take the first 3 in order to qualify for the capacity building funds. We also have peer learning collaboratives that occur monthly, where BHCMs, practice teams, psychiatric consultants get together to meet with a subject matter expert and have a discourse between each other on the successes and challenges of collaborative care, and it creates a peer support environment so that the BHCMs are not operating in silos. We have also a monthly BHCM peer support group where it's just the BHCMs for a similar type of learning environment. And then we actually host a BHCM summit once a year, and there'll be one coming up in April in Colfax, North Carolina, which is right outside Greensboro. And you can get more information on all of these trainings at this link that I've got here at the bottom of the page. Next slide. Below here is just for the past quarter, October through December. So our practice support coaches had almost 1,000 engagements with practices. And as of today, we have 132 primary care practices or advanced medical homes that are now in working order with the collaborative care. And you can see here is a breakdown by Medicaid region. So of the number of engagements we have. Next slide. So just to, I want to highlight several success stories. The first one, Twin City Pediatrics in Winston-Salem. I mentioned Dr. Gretchen Hoyle's office. She worked with our Northwest AHEC practice support coach, Larry Dickerson, to get assistance in implementing the program because she felt that a lot of her patient children in her office were unnecessarily having to use emergency services and inpatient behavioral health at their Novant hospital. So she worked with us to implement this into her system. They use Epic as an EHR. But by June of 2025, the program became revenue positive 6 months ahead of schedule, with monthly cost of $5,400, but over $13,000 that were billed in June alone. So the practice is expecting that their revenues will continue to exceed their expenses by more than $1,100 a month. So this is really important from a financial end because historically behavioral health in primary care has not been well reimbursed. And this just goes to show that it is reimbursable and that also it is financially sustainable. And I mentioned earlier that we can do a pro forma with you to help you get started. And I strongly recommend that so you can know what to expect. Dr. Bree Faulkner, Family Medicine in Spruce Pine, that's in Mitchell County. And you all may recall they were significantly impacted by Hurricane Helene. And this is just a nice success story for them. But they have historically over the years experienced a critical shortage of primary care doctors, but an even greater lack of behavioral health specialists. And so for Medicaid beneficiaries, they've often been referred to specialists way outside the county with lengthy referral delays and transportation barriers. And so to address this challenge, Dr. Faulkner's office partnered with Tara Shields at Mayhec Practice Support to launch their program. And it started in January of 2026. They applied for and received capacity building funds, accessed the CCNC Ames data registry, and they also completed a financial pro forma to help them understand the sustainability of the model. So that's been really exciting to see that happen in Spruce Pine. Next slide. Another success story is Eastern Pediatrics in Greenville. This advanced medical home is located in Pitt County. They reached out to Eastern AHEC Practice Support with Angel Moore and implemented the collaborative care with the clinicians also receiving MOC4 credit as they are actually engaged in a quality improvement project. And in a year-long effort, Angel reviewed the key drivers for quality improvement with them, helping to determine the clinical improvement goal, how to know when a change was actually an improvement, implementing a PDSA process, and reviewing baseline and subsequent data pulls to determine changes resulting in improvement. And as a result of the initiative, providers were able to revise their clinical workflows to consistently screen patients using the PHQ-9 screening tool, document their work effectively in the EHR in the right data fields so that report data can be effectively generated and care gaps can be shown to be closed to the health plans, but also document and follow up with the BHCM for positive depression screenings and implemented the Ames Cake Tracker Registry. And they also contracted with the NC-PAL for psychiatric consulting. And the final story here, ABC Pediatrics of Asheville. And after an extensive multi-year review, Buncombe County's ABC Peds in Asheville implemented COCM in September of 2025 with help from Mark Holmstrom of Mayhec Practice Support. They were able to hire BHCM, partnered with NC PAL, and worked to receive capacity building funds, as well as the AIMS caseload tracker. And they actually ramped up fairly quickly and currently have a caseload of about 60 patients, which is near full capacity for their BHCM. And the patients, the families, and the provider satisfaction are all very high. Preliminary quality metrics are very positive and show patient improvement already. Initial financial indicators are positive, with payments coming in and claims issues and denials held at a minimum. And so we continue to meet with that group on a monthly basis to make sure that they are hitting all the metrics. And so these are just several success stories, but I will acknowledge that in a recent 2026 national report by the Bowman Family Foundation, they also cited some additional practices that we all may be familiar with, including Sandhills Pediatrics, Day Spring Family Medicine in Rockingham County, Mayhec, as well as UNC Duke, Advocate, Wake Forest, and Novant and First Health that are implementing the collaborative care model. So there are lots of folks out there doing some really good work, and so we're very excited about this development. The next slide. And I'll just turn it over for questions and answers.
I'm talking on mute. I'm looking in the chat and I don't know, team, Latoya, Dina, I don't see any questions. That's the first. You guys are just that thorough and amazing that there are no questions. All right, so I will say, as people think about questions, because sometimes they come in late, as you can see, what the team has done, what they always do is they add in links in the chat, so you can find out where you can get more information about the collaborative care model here in North Carolina, about the consortium, about the funding application, about the AHAC coaching. So there's just all kinds of resources about the things that that Dr. McCoy, Eric, and Chris spoke about today. So if you're interested in any of those resources, but let's see, I have a Q&A. Okay, so is there still funding available to new sites? That's a question for the group.
Eric, do you want to take that?
Yes, there is. So contact AHEC and get rolling, and typically practices learn quite a bit through that process and arrive really well prepared to submit an application.
All right. So there's a follow-up to that. How long will funding be available?
It'll be available until it's gone, unless we get sort of a reboot.
Yeah, I was gonna say.
Yeah, unless there are new funds that come along and some other wave of funding, it'll be available until it's gone.
And I would say for those of you, certainly practices for consumers who have experienced collaborative care, for the social workers, psychiatrists, and docs working on this, I think it's always interesting for our legislators to hear how their dollars have been effective. They did give us money for collaborative care. I think it's incredibly effective. So A, thank them, remember to thank them, but B, and I say this to myself as well, when I get a chance and you get a chance, please tell them how their money is bearing fruit. Some of the good outcomes we get, how much access is now developed here in North Carolina. If we need more, we should advocate for that as well. There's a lot of, our team, I want to say, is being modest. There's a lot of national interest. I go places. I was in California a while ago, and a legislator, I believe from Maryland, I introduced myself and he came up to me at the break. He said, I am looking at legislation requiring our health plans to do collaborative care. And I know you guys do it really well in North Carolina. So could you give us some advice? So the work that North Carolina is doing is well known, and people are looking at this model of care. And I think it was really interesting that that was a legislator saying, I hear this model works, and I want to know as a legislator, how can I support that? So, okay, we have another question. What are you seeing as key factors that make a practice most successful in launching this model? I don't know, Chris, if that's for you, but I welcome anyone.
Chris, you're on mute.
Yeah, I'll just comment. I would say make sure that you have both a primary care provider champion and a practice manager champion. That way you've got both the clinical and the administrative leadership all aligned that this is important. I think too is even though you have a primary care provider champion, you need to make sure that at least several folks on the provider panel are committed to doing this, because if you're going to go out and hire or contract for a BHCM and a psychiatric consultant, you're going to need it more than one primary care provider in the practice using this model. It's okay to phase it in provider by provider, but you need multiple providers on board. Now, and if you're not going to do that, then take an honest assessment to see whether the telehealth option is the better fit for you. And there's some very good telehealth vendors out there. In AHEC, we can help you work through that as well. But and just make sure that you are using the data tracker to not only evaluate the outcomes and make sure patients are being effectively taken care of, but also it helps you on the revenue cycle end to make sure that you are getting every dollar that you need to when you bill the payers. That's really important to make sure the model is financially sustainable. And I would just say, finally, the BHCM is the crucial piece. I always thought it was the psychiatric consultant, and that is truly important. But the BHCM is the quarterback. And it's important to make sure that they are fully supported. They're part of the team, that you're not throwing everything but the kitchen sink at them, that you were very specific and targeted for who this population is appropriate for, and that there be ongoing dialogue. And this is a three-legged stool. It's the PCP, the BHCM, and the psychiatric consultant. But it's so important to make sure that they are part of the team and that they're being heard. So Eric and Dr. McCoy may have other thoughts as well.
I think you covered that well.
So I've got another one. Were there any key challenges or lessons that you learned that have come up in scaling the model?
And Chris answered that quite a bit in getting that leadership, both clinical and administrative, on board.
Mm-hmm.
One thing we're really encouraging practices to do is understand your data. I mean, you're submitting it to us, so you now have a view of it. And I've encouraged them to, publish that at the practice level, show staff like what's happening with all this extra work they might feel like they're now doing, that we actually have outcomes. And at the patient level, we've seen many people who have had struggled with depression, anxiety for years and are finally getting some traction on that. So it's got to be encouraging if you work in a practice to kind of hear some of those success stories for something that you're now offering that wasn't there before. Knowing how much they might struggle with referrals, that some people are appropriate to serve in-house within this model. If they're not needing psychiatry and enhanced services, they might be a candidate for collaborative care.
Awesome. Keith, I wonder if you would speak, when I think about scaling too, I think about the individual practice, but also the type of support that you were able to, I know you talked about at the beginning, really to pull together in North Carolina, because individual practices can't possibly, they're awesome, but trying to do it alone would not have worked. And to me, there's a real lesson learned there for other models of care that you guys use to make this successful. So I wonder if you could speak to that a little bit.
Yeah, I mean, I think similar to a practice support champion, we had a departmental support champion in Shannon Dowler, who really got this work going when she was the chief medical officer at Medicaid. Using her political networking connections to bring in all of these folks to the table to be part of the consortium, needing advocates with the legislature, bringing in really a comprehensive strategy for addressing the key barriers that providers were having. I think long term, I don't foresee ever being able to not have any practice support for this. So even when these dollars go away for capacity building, practices are going to ebb and flow. They're going to lose a behavioral health care manager. They're going to need to get a new psychiatrist. They're going to need to consider, hey, can we do this at this new practice site that we're opening? And those sorts of supports, I think, are going to be critical ongoing for providers to have. I think we are seeing large health systems start to really buy into this, and they do have some resources within themselves, but part of what motivates that is the groundwork we did to make sure that all payers are paying for this and that it's a reasonable reimbursement. But there are other incentives that help for this, particularly with primary care practices who serve a Medicare population, because it helps them on some of their performance metrics that assist them in some of their scoring and reimbursement on the Medicare side. So making sure those financial incentives are there in addition to the TA supports is pretty critical.
Thank you, Keith. I think about so many of the whole person care models that have, you know, again, North Carolina really is a pioneer in different models of whole person care or integrated care, whatever you want to call it. And some of the folks here on this call, like Eric in particular, have been instrumental kind of in that history here in North Carolina. But you know, I've been here 18 years. This is the first time I feel like a model has been so wholeheartedly adopted statewide. It's pretty extraordinary, but it really took everybody locking hands to make it successful. But it really is inspiring, if that's not too corny of a word to use. All right, one more question. All right, because I'm just going to be cheeky for a moment. So I want to talk about the most important member of that team that Chris mentioned, which is the behavioral health care manager. I'm teasing y'all. I'm just saying that because that's like the social work role, and I'm a social worker. So, but the question is, who can serve in that role? Like what the licensure or experience of the person who can serve as the behavioral health care manager?
So that person does not need to be licensed. They can be. Whoever they get will need to stay in scope. So if you have a behavioral health care manager that is licensed, they can probably do a few extra things than someone who isn't. But there are very time-limited interventions that don't rise to the level of I'm doing active psychotherapy that someone who has gotten some additional training, such as the 33 courses that we have through AHEC, that someone who is currently already hired or may just have a background and interest that a primary care practice is interested in hiring. We have a whole qualified professional workforce in North Carolina that doesn't have to be licensed. So we tried to be in our policy, and we have it posted through Medicaid, what it is that we cover and who can do it. So that bulletin is out there. We update it with any new information. You know, probably it's been maybe twice a year over the past couple of years we've had updates to do. But if you look at NC Medicaid's bulletins and just search for collaborative care, you'll find the criteria that we've posted, and those individuals that are the behavioral health care managers do not need to be licensed.
For that, Dr. McCoy, and Eric just posted the link for folks who are interested in the qualifications for the staff in the model. All right, I want to say a final thank you to Dr. McCoy, Chris, Eric for being with us today, not just being with us and kind of walking through the model and how it was rolled out, the support it gets, and the wonderful outcomes we're seeing for people. Thank you for all that you've been doing for several years to make this come to fruition. Thank you so much for that. Okay, I'm going to turn this back over to LaToya, who's going to wrap us up today.
Thank you, Kelly. If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our Community Engagement and Training webpage. For more information and resources, stay connected with DMH, DD, SUS by attending our monthly side-by-side webinars and joining our mailing list. The link links are included in the chat box. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar is scheduled for Monday, March 9th from 2 o'clock to 3 o'clock. We will look forward to seeing you then. This concludes our webinar for today. Thank you for attending.